stay in the uterus for too long. And as you can see here, smallness has a direct relationship or a very strong relationship with bad perinatal outcomes. So if you have your babies that are between the 50th centile and the 97th centile, you have the best outcomes. But as the centiles start to become smaller, as the baby starts to become smaller, your perinatal outcomes starts to become worse. All right? So that is the importance of being able to diagnose your small babies accurately. Now, how small is small? That is a question, bro. When do you call a small baby a small baby? Any answers? Please? Anybody? Weeks, 4 weeks. So is it 4 weeks at 20 weeks, or is it 4 weeks at 36 weeks, or is it 4 weeks at 40 weeks? After 26, if it is 4 weeks, okay. All right, so that is a big jump. But let us make it more nuanced and more sophisticated than that, okay? So arbitrarily, smallness is described as a fetal weight or an abdominal circumference of less than the 10th percentile. Some people describe it as a fetal weight or abdominal circumference of less than 3rd percentile. When you do your ultrasounds and you look at the report page, you will see that your reports are given out in percentiles. But when you plot these, in most of the cases, your plots are in standard deviations. So do you know the relationship between percentile and standard deviation? Do you know what percentile means? Okay, we'll do that. Okay, percentile is if you take a population, any attribute, height, weight, any continuous attribute, and you arrange that population in descending order. In ascending order. In ascending order. A percentile represents the point below which you have that percentage of population. So if it's 10th percentile, it means in a normal population, 10% of those individuals will be smaller than that. It will still be a normal population, but most of the people will be above that. If it's 90th percentile, it means 90% of the population will be below that, which means you're looking at a bigger individual or a larger attribute or something like that. Percentile and standard deviations are related. So when we talk about 10th percentile, we are actually looking at 1.28 standard deviations. Not an important number to remember. But when we look at 2 standard deviations, we are looking at 3rd percentile. So when your figures, when your numbers are at the 2nd standard deviation, you know, the line at the bottom that you all are very aware of, it means that that particular attribute is at the 3rd percentile. And you really need to start taking that seriously. Now the problem with 10th percentile or the 3rd percentile is that there is a huge overlap. So what happens is that if you take 3rd percentile as your cutoff to distinguish normal from abnormal, you will get all of the abnormals, but then you're leaving a huge number of abnormals that you're labeling as normal. So the FGR is this orange area and normal is this gray area. If you take 10th percentile, you're getting many of your abnormals, but you're also labeling a lot of your normals as abnormals. You don't want to do that. It gets even worse. Even if you go beyond the 10th percentile, you still have a significant number of babies that are FGR. That's not very intuitive, is it? That you have a baby that is in the 50th, 60th percentile, but it's still FGR. So that is a special class of FGRs that we are going to discuss later in this talk. So if you take any population of small babies, About 40% of them will be FGRs, as expected, as you want them to be. But an equal number of babies will be SGA. They're just small. They're determined to be small. They're just short height. Some people are short height, some people are taller. So these are just short babies that are otherwise normal. And 20% of babies, they're not deprived of nutrition. They're not starving babies. And another 20% of babies are very ill. They either have a chromosomal problem or they have an infection. And these are what you get as early FGRs at about 20 weeks or even earlier than that. So we have just discussed that simply taking one measurement of fetal size is not going to be very useful for you to enable you to diagnose or to distinguish FGR from small babies. Okay, so what do you want to do? You want to look at growth velocities. Okay, and how do you, and we'll discuss how to take a growth velocity. And you want to take a Doppler. And in a Doppler, you have a huge menu of things that you want to put on your table and you want to analyze and then use all of those data that you get to make your decision. And in the future, you might get biochemical markers. They're already in the market, but they're being studied as to their usefulness in the diagnosis of FGR. Smallness. When you say a baby is small, Madam said that 4 weeks. It implies that you actually know what the size should be. ठीक है ना? The baby should be 30 weeks, but the baby is 26 weeks. That is a primary prerequisite requirement. Okay? So that means you need to know the age of the baby. And how will you do that? LMP. You do that with an LMP, or you do that with an early scan at 11 to 14 weeks. Or if it's an ART, you know the date of conception. That is perhaps the most important. Okay, when you're talking of LMP, you must remember that not every woman who claims to have a normal LMP has a normal LMP. About 65% of women will have a period that is about 25 to 30 days, which is called normal. Many normal women will have their periods that are longer than that. And many normal women will have their periods that are shorter than that. So just a question, when was your LMP, does not satisfy the conditions. You need to ask, when was your LMP? You need to ask if she has irregular cycles, and you need to ask about the duration of the cycles. Okay, so you need to have this three information with you before you can make any assessment of the age of the patient. Better than an LMP is an 11 to 14 week scan, and I'm sure Dr. Fazil will be talking about it directly after tea, and I'm looking forward to hearing that talk. And I'm sure he's going to tell you how to actually do a 11 to 14 week scan. It is not as simple as it sounds. It's perhaps more difficult than doing a second trimester scan, and you need to satisfy a lot of conditions to get that. Now, it is very important. Once you have assigned a date, by any means, you are not allowed to change it. Okay, you cannot say, आज देखा तो 26 October उसकी expected delivery है, and then when you see next, no, let me change that. It's not 26 October, it is 10th November. You can't do that. Your date assigned at the first scan is fixed. And then you cannot blame the date, you can blame the baby's size. You can say that the baby is not growing as well as expected, or the baby has accelerated its growth, or something like that. So you can't do that. Okay, so we touched upon it. FGR is important to diagnose because it increases perinatal mortality, it increases postnatal complications, and you can actually do something about it. So what's the point of diagnosing something if you can't help it? And you have some very strong data. In the UK, they started something which is called GAP, which is Growth Assessment Protocol. And once they implemented it in the population, the perinatal mortality declined. The number of fetal death declined. And this is a very significant drop. See, from about 5.26 to 4.3 something. So it is very important because you can do something about it. When you're doing FGR, it's not only ultrasound. The moment the woman walks in, the moment you have taken her